All right, guys, welcome to our next session of EMS training. Today, this is a protocol review for fentanyl, and we're going to talk about it, roll through the protocol real quick, and short and sweet, kind of go over it. Everybody should be pretty familiar with fentanyl already. We've had it for a long time, and everyone uses it pretty often. So it's definitely an easy one, but it's something we're just going to brush on up here, have a review. And then we'll have another video about medication administration, and we'll go over a little bit more there of when we give it, different ways to give it, how it can be given, etc. So this is just from our protocols. You can follow along with me on this. You can follow along on your phone if you want. If you open your app up, you can just follow along on that. If it's easier to read on your phone versus watching this screen capture here on the video. So whatever you want to do. So this is just from our protocols. 16P in the formulary section is where you'll find this. We got fentanyl, name brand of Sublimase. Don't really see that really ever. I don't know if I've ever actually seen Sublimase name brand, but fentanyl. We carry this on our trucks. Pretty much every service in the world uses this. One of the most commonly used medications for pain. Paramedic level only. The only you can't be an advanced and give this. You have to be a paramedic. And the reason being, it's a narcotic, analgesic. That's its class. So this is a narcotic. It is monitored by the DEA. It's kept under lock and key in our medics and in the medic vaults in the station. And we have to track each and every one of this from the point that it's bought until the point it's given or thrown away. So how does it work, man? What does the pain medication actually give for you? We look at the actions here. Stimulates the central nervous system opiate receptors, producing systemic analgesia. On a milligram weight basis, fentanyl is 50 to 100 times more potent than morphine. Its duration of action is shorter than morphine or hydromorphine. An IV dose of 100 micrograms of fentanyl is roughly equivalent to an IV dose of 10 milligrams of morphine. Fentanyl has less emetic effects than other narcotic analgesics. What's that tell us? Why do we use fentanyl? We use it because it's very powerful in low concentration. It has a short duration of action, it says there. And so we can give that 100 mics of fentanyl, which is a couple of cc's, versus the larger doses of morphine, or multiple doses of morphine. It has less emetic effects, so it doesn't cause you as much nausea as morphine does. If you ever had morphine, that is a big common complaint for most people with morphine, is that while it works great, it makes them sick to their stomach. Okay. And that's it. That's roughly very simple. Okay. Looking for some indications. We can use fentanyl in a lot of ways, on a lot of different types of calls. The main one that we're going to use it for, that covers all of these. Apologize, guys. My iPad freaked out. The main one that we're going to cover here is, or the main one that all these covers all of these, okay, is pain management and then ACS would be the exception to that rule. But going down the line there, we'll talk about those. Chest pain, uncertain etiology, we use fentanyl to manage the pain. ACS, we're using fentanyl to manage the pain. Snake bites, manage the pain. Abdominal pain, manage the pain. Pain management, eye injury, dental injury, chest, abdomen, pelvis injury, extremity amputation, compartment syndrome, crust injury, burns, lightning, electrical, pelvic pain. For all listed situations, indication is acute pain control in an alert, hemodynamically stable patient. Okay, so there is your indications. All of them can really be covered with pain management. So the ACS is the only one where we're looking for the ACS. We are using it for pain management, and then we're also we like the secondary side effects that it has vasodilation, right? So do you give morphine or fentanyl in ACS? Okay, so we always talk MONA, morphine, oxygen, nitroaspirin, right? MONA. Really, we know that anymore we we give what manages the pain. So you can give fentanyl, it works just as well. And we also know that a lot of the vasodilation that morphine supposedly did in crushing blood pressures is not as true as we thought it was. It doesn't vasodilate the vessel. It doesn't dilate the vessels in the heart as much as we thought it did. So fentanyl and morphine is roughly the same thing. So if you're more familiar with fentanyl than you are with morphine, just give fentanyl during your ACS calls. And then other parts of MONA, such as oxygen, that we don't use anymore, unless we're indicated. So, all in fentanyl, though, contraindications, hypotension, respiratory depression, minor degrees of pain, and pain assessed as fictitious. Okay, so we always have to get a blood pressure before we give pain medication. We should not give fentanyl to somebody who is already having problems breathing, even if they're in a lot of pain, because the fentanyl may completely stop their breathing. We don't give fentanyl for minor degrees of pain. Best way I ever heard this described was by a pediatrician at a conference I was at, and he said if we told parents that we were giving your kid heroin for the scraped knee, they would sue us or lose their minds. Okay, so we're not going to give fentanyl, especially to younger people, but we're not going to give fentanyl for something that's just a minor degree of pain. Fentanyl is a serious drug. It's a narcotic, and so obviously use your discretion. Next, pain assessed as fictitious. This is one that can get you in trouble very quickly if you create it. Some people live and die on this. So all pain's fictitious. And okay, so if the person is reasonably in pain, it's a good idea to give them pain management treatment. But obviously we don't want to contribute to somebody's drug seeking behavior. Okay, so, but obviously use your best judgment and your skills that you have and your experience to assess them and decide whether they need fentanyl or not. Side effects of fentanyl: hypotension, respiratory depression, euphoria, dizziness, nausea, and or vomiting are rarely seen if administration is slow IV push. Okay, so it will drop your blood pressure a little bit. It will slow your breathing down a little bit. It'll make you euphoric, can possibly make you dizzy. And sometimes they can't have nausea, vomiting. There are people that when they give fentanyl, they always give Zofran. I want to caution you on that, giving them at the same time, always preemptively. Zofran does have some complications. It's not just like you're not giving them water. It is a medication, so if they're not nauseous, probably don't give them Zofran preemptively in case they have a couple of cardiac problems that can lead to some serious side effects of Zofran. So just be careful about routinely giving, preemptively giving medications such as Zofran. There's lots of ways that you can give this to slow down the nausea. One's to mix it in a flush, shoot out 3 cc's of fluid out of a flush, and then draw the rest of the fentanyl into the flush so that it is diluted some, so they don't get it. It doesn't hit them as hard. You can, if you have a bag of fluids running, you can draw fluids in there to dilute it, etc. And then obviously push it slow. It's sometimes hard to push, especially if you use a 10 mil syringe and you only have 1 or 2 mils of fentanyl, and it's hard to push that slow because it's such a small distance. So use a smaller mil syringe, or mix the medication in a flush, make it easier on yourself. Pharmacokinetics: onset action nearly immediate after IV administration. Peak effects occur within 3 to 5 minutes. Duration is 30 to 60 minutes with a half-life of 6 to 8 hours. Okay, so very short-acting drug, very powerful, very short. That's one of the reasons why we use it. In case something goes wrong, it wears off pretty quickly. So how much do we give? All of these kind of works the same. They have one pulled down there, the dose is there. All this works pretty much the same. We give 0.5 micrograms per kilogram, slow IV push. Cut. All right, so dosages. How do we dose this? How do we give it? Oh, there's 2 different dosing systems you can use. One being ACS, which goes, you're going to give a maximum single dose of 50 micrograms and may repeat every 10 minutes to a maximum dose of 1.5 mics per kilogram or 125 micrograms, whichever is less. Okay, so that's for ACS only. Okay, so you see people, we had a medic here that sent this to me once, and I was asking them about fentanyl on a QA, and they were using this as the pain control. This is only for ACS. Okay, single dose of micrograms of 50, that's the ACS dose, not the pain control dose. Scroll down to pain control for all the situations from above. So chest pain uncertain, ACS goes with that. All the rest of that goes with this. And this is what you're commonly going to use. 1 microgram a kilogram, slow IV push. It can be IV, it can be IM, and it can be IN in the nose. Maximum single dose of 100 micrograms may repeat every 10 minutes to a maximum cumulative dose of 3 micrograms a kilogram or 250 micrograms, whichever is less, right? So we can give 100, 150, and then we're done without med control, okay? So that's quite a bit of fentanyl. That should take care of the problem, okay? It's just important you see people, don't be afraid of fentanyl. It's really safe, it's been around for a long time. You see people underdose this a lot, and then they have to give it 4 or 5 times, and you have a patient that's in pain for 20 minutes when there's really no reason for them to be. We could have took care of that if we follow our dosing chart correctly. Okay? So I would say your most common doses are to give 50 or give 100s. It's definitely going to be hard it can be hard, I guess, to calculate 75 if you're in the middle. So most people use 50 and 100 as their guideline. Pediatrics. Okay, so scrolling down here, the pediatrics on the bottom, online med control only. All pain medication for pediatrics is you always have to call and ask for this. You'll get it if the kid's hemodynamically stable. Pediatric physicians are not afraid to let you give medications, these types of medication to kids. Typical dose is 1 microgram a kilogram up to 50 per dose. And usually you're only going to give it one time with a kid. You're not going to hit them multiple times. Last there is how it's applied. We got 100 micrograms in 2 mils, 250 in 5, 500 in 10. And there's lots of ways. It can come in an amp, a vial, a syringe. Okay, the most important part of that is always check concentration per dose at time of patient medication administration. Super important because shortages happen and things get switched out. And Chief Blevins does a really good job of letting us know when things change, but things can always change day to day. So, you know, in a perfect world, we would always know exactly what's on the truck, the exact brand. It's always going to be standardized in the exact same size, and I would say 99% of the time that's true. And then if something changed in a perfect world, we'd always get it passed on from the crew in front of us and down the line, and everybody would know what's going on. But communication sometimes can be broken. So in the end, to protect yourself and your patient, always check your concentration on how much is in the dose, and before you give it, always verify it. So simple, easy, guys. We'll go over a little bit of how to give this and why we should give it in different ways in the medication administration section. But I appreciate you guys watching this. It's just a review of this real quick. A short, easy training today. Thank you guys for watching, and I will talk to you soon.